That's fine. Thank you. Okay. All right, thank you. All right, so let's get started. Okay, I'm Danielle Lynch. I'm a student physical therapist, and I'm with Moorings Park Outpatient Rehab for my clinical rotation. And this is my presentation on E-STIM. So it's a good little overview going back to what we learned in school and updating you on the current research we have upon it right now. So these are just some learning objectives. I hope we can do a nice review of parameters, why you use them, a little introduction to each of the rationales for selecting, and an understanding of what current is and what it does. And there's a handout, guys, on the first chair. Jesse, if you want to get the first. Yep, thank you. All right. So here we go. So basic uses, the ones that are supported by research, evidence-based, are edema control, pain management, muscle contraction, muscle strengthening, and muscle re-education. We also have iontophoresis, which is good for transdermal drug delivery as well. So you can actually deliver things like dexamethasone, corticosteroid to the patient through their skin. A little bit, an alternative method of delivery. So E-STIM was not a recent discovery. It's actually the first recorded evidence of pain management was in 42 BC with the discharge from a torpedo fish. That was pretty cool. We have Duchenne, a French neurologist who mapped out the motor points back in 1791. And he tried to approximate where the best place was to apply electrical stimulation to get the best muscle contraction specific to the fiber. And then we have Faraday discovering bidirectional alternating current by inducing that moving magnet. And we have the first use of iontophoresis recorded was in the early 1900s. It's not that new. Okay, what is current? So to understand current, you have to understand that electricity is a force. It's a force caused by a difference in charge, basically. So you have to have a difference. You have to have an area of cathode, which is a negative pole, and you have to have an anode, which is a positive pole. So current flows from levels of high concentration to low concentration. So like if you have a typical battery, you're going to have that cathode, which is going to have a high concentration of electrons, and they're going to flow to the area where there's a low concentration of electrons, which is that anode. And that will go on forever because a battery is a form of direct current until those two sides are even. And at that point, you have a dead battery. There's no more electricity. The force is gone, basically. Okay, so current takes the path of least resistance, so we have to remember this when we're placing our electrodes. Where do we place them? We're going to place them on tissue that's more vascularized because it has water, which is a great conductor. And so we need to find things like nerve and muscle with vascularization as opposed to things like tendon and bone and cartilage and fat, which are going to resist current flow. These are some current attributes. If you're really interested in the physics, amplitude is the intensity depicted by the magnitude of the wave, how high it goes. That's what you're going to feel. It's the power. It's the intensity of the contraction. I'm sorry, it's a little hard to breathe. And the mask, I'm like inhaling it. Okay, and then frequency is the rate. Frequency is how many pulses occur per second. It's how many are waving per second. Okay, and then you have the phase duration, which is the length of time that the phase is happening. That's the length of time that machine is on. That machine is stimulating a current. When you have gaps, like depicted in D, that's an interpulse interval. That is when machine is off, no current is being delivered. Okay, types of current. There are really two types of current, direct and alternating. Direct is this box just marching relentlessly onward, like the battery. Alternating current is a reversal of polarity. So you have basically the poles on either side are reversing polarity, and it's causing this sinusoidal wave. Okay? And those are your forms of like interferential, Russian, and pre-modulated current. Pulse current is a form of direct current with rest period, times when the current turns completely off. And here's some of those medium frequency alternating currents. Interferential, there's your Russian. It's not the best picture. They're very close together, but you have these gaps when the machine turns completely off. Biphasic kind of looks like alternating current. And it kind of operates like it too, but it is technically a form of pulsed or direct current. A little confusing. They're still calling it pulsed current. Okay. Terminology. Here's some terminology. Just going back to that action potential, that good old action potential. The motor point is where the nerve penetrates the muscle, where it innervates it. And that's where your electrode should go, one of your electrodes, if you're doing something like Russian stim contraction. Normally, physiologically, we have something called an action potential. It's the messenger unit of the nervous system, and that's propagating the message to the presynaptic and postsynaptic terminals to to send the signal, I need this muscle to contract down the axon. Okay, so then we have depolarization and repolarization. So depolarization is when we get that cell membrane or postsynaptic, whichever membrane we're trying to depolarize to create that, to move that message along. The resting potential of the cell is negative inside normally and positive outside. So when we give enough frequency and enough amplitude to cause a stimulus to send that message, we're telling the Na channels to open on the membrane, and Na, or sodium, rushes into the cell, and then it causes it to become more positive, and that's the depolarization. And when it hits positive 30 millivolts is the threshold, really. When it hits that point, causes the potassium to rush into the cell instead. Those channels open. They rush into the cell, and they cause it to go back to its state, repolarizing. And then there's a period of time where nothing you can do is going to stimulate another contraction, and that's the absolute refractory period. And then there's this hyperpolarization phase where you need a huge stimulus to tell that, to continue to communicate, and that's the relative refractory period. And then we go back to the resting state. Okay. All right. And that's just how the message travels. It actually jumps like this in between these little node areas, the nodes of Ranvier. This is where the action potential happens, and then depolarizes, repolarizes, and hops to the next. It's going over these fatty sheaths called myelin. And that's actually called saltatory conduction. And there it is again. So you see the little action potential happening in this node area. Okay. This is a very important slide. This is showing from left to right. This is showing you the order of neuroexcitation. You're going to need, everything is dependent on current strength, the amplitude, and the pulse duration to target a specific nerve fiber. So with, let's say, pain control, we're trying to stimulate these beta neurons, nerve fibers, that are the light touch. If I were to go up to Kelly and tap her on the shoulder, this is the light touch sensation. We want to reach out to that. So we have to set our parameters to hit that minimum, this is a low pulse duration and a pretty high frequency, to get to that sensory area. It's because we want to, and I'll explain this later, block input from sharp pain areas and dull pain areas up here. So we want to get to them first. So that's why we set the parameters as we do. And this is the order of how we recruit based on time. Okay. So physiologically, there's a difference here with E-STIM. E-STIM, we're putting something on the surface of the skin. So we're using the principle of flow, of ions, and we're recruiting based on flow and how many ions that nerve fiber has. Something with a large diameter has more ions in it, so it's going to get recruited first. It's more responsive to the current, and that's why we can target those beta fibers. They actually have bigger diameters. And so we reach out to them by setting our parameters to get the frequency needed to stimulate them first. Okay. So physiologically, though, what are we doing? We have a neuromuscular junction, and everything's coming from the nerve to the muscle. It's taking a different route. So you're going to see, especially with Russian current is going to target the large type 2 glycolytic fast twitch muscle fibers first, whereas physiologically, we recruit those small postural fibers, the slow twitch ones first. They take less energy to use, and our body recruits them first, then it recruits the big power horses if it needs some more powerful movement. So we're kind of, it's slightly different than physiological contraction, and you have to keep that in mind when you're using Russian E-STIM, because you have to reteach that person how to recruit their postural muscles again too. Okay, and this is just the motor point, showing the motor point. If you can't find the motor point and you don't have one of those fancy motor point charts, I would suggest having the person isotonically contract. Then you palpate and you feel for about middle of the muscle belly to about the upper third of the muscle belly. And that's usually where the motor point is. It varies on atrophied muscle. Okay, considerations for electrodes. I'm not going to read all this, but basically, if you see that the electrode is getting dull, that's the conductive medium, that gel. If you see it's getting dull, throw it out. That should be about 8 to 10 uses. I know we can't throw out an electrode every time we use it, but it's going to lose its conductance, and you might actually burn or hurt the patient if you keep using the same electrode for months on end. So if you can, throw them out after 8 to 10 uses. Okay, and then safety, always make sure that the machine is off before you remove those electrodes, because this has happened to me. It's burned me when we're practicing in lab. And so make sure it's turned off, and then only increase amp when you're doing something like Russian stim, where you're trying to get that good muscle contraction up to the patient's tolerance. Don't ever increase the intensity when they're resting, when the current is off, because the next time it hits them, even with that ramp time that kind of slowly moves them into that contraction, it's still going to kind of shock them. It's going to be too much. So increase it while they're already contracting. If that makes sense. One more point on that is electrode placement and current depth. So this is why I think IFC, and science thinks IFC works better than TENS, is because, and pre-mod as well, is because when you space the electrodes farther apart, this is how the field lines travel. They travel deeper and deeper into the muscle. So, and you can use this concept for targeting chronic pain areas, but you can also use it if you want a deeper muscle, like supraspinatus, underneath the trap. I would space out the electrodes a little bit more if I want to recruit that. Direct current, talked about this. It's continuous flow in one direction. And iontophoresis is really the only use besides maybe a denervated muscle, where you have to forego that neuromuscular junction completely and just stimulate that full muscle belly. So this is kind of uncomfortable. It feels like a needling almost. I'm not a huge fan of it, so I can only tolerate about 3 milliamps per minute. This is a dosage, so it's time dependent as well as voltage dependent. So if I want to deliver a drug to a patient, I'm going to have to if I want to set it to 1 milliamp minute, and that's all they can tolerate, they don't like the sensation, it's going to take 40 minutes, like a 4-to-1 ratio, for them to get that full delivery of the drug. If I set it to 4, it takes 10. So this is for transcutaneous delivery of drugs as an alternate method other than GI, and it works because like charges repel. So you're going to set this active pad here with a nice buffer solution so we don't cause any acid or basic burning. You're going to set this to the same polarity as the drug. Dexamethasone is a negatively charged drug, and so you're going to set this active to negative, and the like charges are going to push it through the skin to this dispersive area. So it's going to go from here down here because the charges are being pushed away. And it increases the permeability of the skin as well, because of those membranes they have charges associated with them, and it will increase the permeability of that outermost stratum corneum. And that's how it works. Okay. I'm just going to read the precaution really quick here. So just make sure that you watch their skin, because it does have a little irritation and redness associated with it. So always check the skin, clean the skin before you apply the electrode to it. And don't use anything that can increase permeability, such as ice, heat, or ultrasound before, because the whole procedure operates on permeability, and you don't want to alter anything here. And then you don't want to use it with any malignancy or cancer, because you might cause it to metastasize. So we're moving things. We don't want to move cancer. Okay, this is just showing some of the purposes of corticos. The dexamethasone decreases inflammation. So, and it's each drug has an associated charge. There are much more than this. These are the 4 most common ones. Okay, alternating current. I just wanted to make a few points here about interferential current. If you see this on the Chattanooga, carrier frequency is different than beat frequency. On your little chart, your handout, I have the rationale for the parameter setting. When it says high frequency, we think of that as what, 80 to 150. We would say that that was high. Well, if you're talking about B frequency, that's true. If you're talking about carrier frequency, that is something else. It's stimulated by the machine, okay? And this is actually a medium frequency. A low frequency would be 1,000 hertz, and a high carrier frequency would be 1,000,000 hertz. So Russian and interferential, they're all medium frequencies. You really wouldn't toggle with this. It's just creating that X. So when you do interferential current, right, we have 4 electrodes, and we cross them so that in the middle we have this area of targeted interference, okay? And that area is that beat frequency. It's actually the difference between this lower carrier frequency and the higher one that's not pictured on here. So in this case, the higher one would be 4,080. The lower one is 4,000. The difference between the two is the beat frequency, which you see on your sheet. And so you don't really have to worry about this. I just wanted to point out what that was, because it's confusing. So you're looking at the beat frequency. And with interferential, there's a beat low and a beat high. And this is just a modulation, so it goes between the two. Okay? And here's some placement of IFC. Of course, you cross the 2 channels across each other like this, like in an X pattern, and you can cross the spine with interferential current. It's penetrating deep. So it's further apart, those field lines are going down, and it's great for pain modulation. Okay? And it's also thought to be more comfortable. I've personally tried both pre-mod and this one and TENS, and I think this is the more comfortable one, personally. Because it's delivering like a low amplitude to the surface of the skin, and it just goes deeper and it targets what you need it to target as well, but it's less on the skin, less intense on the skin. This is Russian. Russian has a burst frequency, and it doesn't have continuous flow, so it's going to have a duty cycle. 50 is okay, 20, 50. The cycle time is important because that's going to determine your treatment time. So if I wanted to have 10 muscle contractions for this patient, right now as it's set, it's going to have a 10-second contraction, let's say of the quadricep, and a 50-second rest. So it's going to take me 10 minutes to do 10 full contractions. And again, you're going to do the muscle contraction with your own active voluntary contraction with this, because you want to retrain everything. Small and large muscle fibers. Okay, just a little bit on this. There's a 2015 systematic review. Russian was just as effective as pulsed biphasic for strengthening. And then we have pre-modulated. Pre-modulated, the difference between this and IFC, you see the carrier frequency went away. It's actually mixing the frequencies in the machine before it gets to the output. And that's the difference. So it's pretty much a preset for you. It's good for areas that are smaller and irregular, like a smaller muscle where you can only fit 2 electrodes, because there's only 2 electrodes and 1 channel involved. And you can also modulate this one as well and keep the sweep on. All right, so 2 electrodes. Those are 2 separate channels. They're doing 2 separate pre-mods. They're not crossing, as you can see. It's easy to set up, but it lacks that ability of IFC to really penetrate deep and not affect the skin as much. Lower amplitude on the skin, deeper amplitude beneath. Pulse current, monophasic. I'm going to skip through this one really quick. The thing about monophasic is you have to set the charge depending on what you're doing. If you're controlling edema, it's a negative charge. And if you're pushing, if you're doing high voltage pulse current, which is how we deal with wound healing, you have to match the polarity to the stage of the wound healing, depending on what cell types you want to recruit to that area to help with healing. Biphasic is our TENS. It's our most versatile waveform. Controls pain, and you can toggle, sorry, back there, you can toggle the phase duration and the frequency on here, depending on whether you want chronic or acute pain. So it's very versatile, and you can also use it for, I've seen it done for muscle contractions as well. So you can utilize this one. Most machines have this function. Okay, contraindications. I was asked about several different kinds of like heart loop implanting devices to see if they were also contraindications. We know we don't want to mess with a pacemaker. I think we're all familiar with that. Any kind of condition of the heart, rhythm condition, arrhythmia, no. Any type of movement, we don't want to move a thrombus into an area where it can cause a PE, anything like that, pulmonary embolism. And we don't want to put anything over the carotid sinus, which communicates to our heart to beat. So we don't want to affect that. Pregnancy, we don't want to cause any kind of premature exodus of the baby, so we do not do any E-STIM near a pregnant woman's abdomen or back. So any kind of implantable device is also assumed to be a contraindication. If you don't know how it's going to affect, if it has any kind of pump, like a baclofen pump or an insulin pump, no. It's right now research is saying try not to, because they just don't know what it's going to do, and it's kind of ethically difficult to get the IRB to approve a study as of now to see what effects it would have. We don't know. So when in doubt, question mark, probably a contraindication. Okay, and these are just some things. Malignant tumor, I would move that up to contraindication. It's still at a precaution right now. And if the patient doesn't know what's going on, they don't understand this procedure, I wouldn't do it either, because the stimulation would scare them. We don't want to do that. Okay, this has already been spoken about, but we're recruiting the fast twitch muscles first. NMES means neuromuscular electrical stimulation. And then you might see something that says FES, that's functional electrical stimulation. That's when you do a contraction with a movement, like a sit to stand. Okay, I'm gonna ask them to actually sit or stand while the contraction is happening on their quadricep, for instance. And functional electrical stimulation is more used with stroke patients. Okay, overload principle, you apply more load, you're gonna gain more resistance, you're gonna gain more strength, basically. So it's an overload principle. So we're trying to up the forced contraction, so we're trying to get the patient to be able to tolerate as much as they possibly can for the muscle contraction within reason. So we're trying to increase that pulse duration, current amplitude, and electrode side when we're building strength. There are a few interesting studies, so it works. It works, Russian stim works. For things like enhancing recovery of strength and speed of recovery, definitely works. We've seen this with soccer players that have added neuromuscular E-STIM to their rehab protocol. So in conjunction with it, it seems to work because they are doing those voluntary contractions as well. And we've seen some good results with post-op strength as well. So if you do NMES before for a total knee replacement, there was a systematic review done on several studies that looked at NMES before surgery, and it showed that these people had greater post-op strength, even though they did it before the surgery, which is interesting. And research is still being conducted in that area. Definitely have support for total knee replacements, doing E-STIM for Russian to improve your quadricep strength. That's a pretty, it's an overdone area. The quadriceps are usually stimulated. And then we have cardiopulmonary patients. There's a huge interest in how do we engage these patients to gain strength. CHF, interestingly enough, I would not ever do E-STIM on a CHF patient. Apparently they did this for the study because, you know, that organ system's already failing. I wouldn't increase any E-STIM to that area, but they did this study. 218 COPD, thoracic cancer, and CHF patients at a higher rate in regaining quadricep strength when they used Russian stim, but there was no muscle layer thickness hypertrophy. But they increased their strength. It was very interesting. Astronauts at anti-gravity, they found success with a case study done with an astronaut where they would stimulate the antagonist muscle with E-STIM and have them voluntarily contract the agonist against that because you lose gravity. So you lose that ability to work against gravity. So now you work against your electrical stimulation. So the E-STIM would be in the tricep area. He would contract the bicep against that contracting tricep. Very cool stuff. It worked pretty well. They did a cross-section of his, I didn't put the picture on here, they did a cross-section of his quadricep and they found it was the same as when pre-flight, and as the same as several months in the International Space Station. So he was able to retain his mass. Very cool. Okay, stroke FES is as effective as wearing an AFO according to several studies in a systematic review done in 2015. It increases strength, it improves activity, and sustains activity beyond the intervention. Also, centrally, it reduces spasticity, which is a very interesting concept. So with doing antagonist contractions as well. SCI patients, this is great, having them E-STIM while reaching for an object or doing some functional movement, doing some exercise movements like leg cycling and rowing, arm cranking can also increase their muscle strength. So they put the neuromuscular E-STIM on them while they were doing bicycling and moving, and they found that they also increased strength as compared to a control group. And there's also been evidence in children with cerebral palsy that if you combine it with dynamic bracing, you're going to see gains in muscle strength, especially grip, postural gains as well, and reduction in spasticity. Okay, this is more for the OT population. There has been success in dysphagia, treating swallowing disorders by placing on the neck area by the pharynx. I saw in a study. So that was pretty interesting. Urinary incontinence, they have a lot of transvaginal and other devices to engage the pelvic floor. Convincing patients to do that is quite another battle, but this is a developing science. So, but it has been shown to help with bladder voiding control as well. And then edema control. So you get that muscle pump. If you stimulate the calf, you get that muscle pump to pump fluid proximally back to the body. So it's very beneficial there as well. This is included, I'm not going to read this, this is included on your sheet. This is all about the electrode places, the best place to put it, and as well as best patient positioning. It's on the back of the sheet, and this is a little snippet of the front of your sheet. Okay, E-STIM for pain control. So we have gate control and opioid release. So the gate control theory is that acute pain theory, where we have sensory TENS we usually engage. So if you want to engage your sensory TENS, you want to set that frequency pretty high. Okay, so that's on your sheet. It's about 100, 80 to 150, I think is the range there. You want to block, with the gate control theory, we're trying to block the A delta and the sharp pain and that dull pain C fiber stimulation sent up through the spinal cord to the brain. We want to tell it not to send the pain signal. So we block by activating those A beta fibers, which then activate an inhibitory interneuron, which then say, don't send that signal. Opioid release is that chronic target. And we have some overlap between the two. But it's going to stimulate production and release of endorphins and enkephalins from the hypothalamus down to the serotonergic tract, the descending tract. And that descending tract is going to synapse with the enkephalin tract in the spinal cord itself. And that's going to synapse with the inhibitory neuron to tell it not to go up to the brain. So it's similar, it's just a longer process. And this works because that enkephalin receptor at the bottom in the spinal cord releases things like morphine and endogenous opioids that the body produces naturally to bind to the opiate receptors and basically block calcium from going from stimulating vesicles in the presynaptic and postsynaptic terminals to send the neurotransmitters to send the pain signal. That's the nutshell version of that. So we're going to stimulate that chronic pain with a lower frequency and a higher pulse duration, which is depicted in your parameters on your handout. And this is just what I said about gate control theory. You're blocking that. You're sending that inhibitory signal to close the gate and tell it, no, don't send that pain signal to the brain. No. Okay. And that's what I said before. So you are blocking the opioid binds, it closes the calcium channel. The calcium cannot bind here and send neurotransmitters across because it's blocked. Okay? And there's also an opiate receptor on the postsynaptic area as well. Okay? So we found that chronic pain, and I just wanted to add this about, there's no conclusive evidence that supports lower back pain treatment with TENS. IFC, yes. TENS I don't know. There is just nothing that conclusively says that TENS works. Maybe it's because lower back pain is such a huge animal. Okay, so IFC definitely reduces osteoarthritis knee pain, and it definitely I don't know if this is part of a placebo effect, but a huge study done on 150 participants with lower back pain showed that with an IFC treatment, they stopped taking pain medications as much with chronic pain management. So that was good. So they used this instead. But they did not say there was a huge change in the pain intensity. But they stopped using medication. So I guess it's a win in one area here. For acute, it's acute high-frequency TENS. There was a study done showing that it decreased 50% of post-op pain here, basically. It's better than the placebo for reducing pain after operation. Okay? And these are the three waveforms, IFC, pre-modulated, and TENS that we typically use for pain management. Okay? Amplitude treatment should be comfortable. So this is the sensation so that you know you're at the right amplitude. You really want them to feel a strong sensation of tingling if you're trying to address that acute pain. And if you're trying to address that chronic, you're trying to get them to actually, the muscle to see it visibly contract, or you can feel. You can actually put your hand on and feel. So you're setting the intensity to produce that muscle contraction, all dependent on patient tolerance. And this is a snippet again of what's in your little handout. This is TENS electrode placement. I'm just showing you that the channels don't cross. And this will come with any TENS unit. It usually gives you a guide of where to place. And you use your own clinician rationale to space it if you want to penetrate deeper as well. Okay, soft tissue healing. This is the last few slides of the presentation. So, soft tissue healing, we're not really dealing with this population here, but I just wanted to reiterate that there are three mechanisms whereby this promotes wound healing, and that's galvanotaxis, cell activation, and an antimicrobial effects due to that direct current. So galvanotaxis is that directional movement of cells in response to the electrical field, and you're going to appeal to the stage that you're at in the wound healing process. So in the inflammation stage, you set your parameter, your polarity to negative. If you're in the proliferative stage, you set your polarity to positive, because that's the charge that's going to attract the opposite cell to the area, oppositely charged cell to the area. So in the inflammation stage, we want these neutrophils, macrophages, lymphocytes to come to us. So we're going to set it to negative, and they will be drawn because they too are charged to that area. So we're just speeding up the process. Okay? You're also going to have this. The skin itself is kind of like a battery. The membrane is charged. So inside the cell, it's negative, and then when you rupture, you're having these charged ions leak out of the cell. So that center of the wound also becomes charged. It becomes positive charge relative to the outside area. So it's changing its charge as well. So that's going on. And then cell activation. This charge polarity is kind of encouraging fibroblasts to be activated because they too are charged. And so this helps mainly with the proliferation phase. You're going to set it to positive, and they are negatively charged. They're going to go to the positive area. And this is going to trigger calcium channels in the fibroblasts to open, increases intracellular calcium, and eventually, it's a very long, drawn-out process, but it's going to expose insulin receptors, and it's going to synthesize collagen and DNA. So collagen gets laid over the wound faster. Bottom line. Okay. It's a little dense, so. All right. So we definitely see that it does indeed accelerate wound healing. It's successful for doing it at little cost and with little adverse effects. So it is trying to be pushed more. Pressure ulcers is another interesting area. It itself, this high voltage pulse current, this monophasic current, actually can decrease the ulcer size, which is interesting. And it increases the likelihood of wound closure because of all the collagen being laid down as well. You can, going back to Russian stim, just a little side note about pressure ulcers, if you use Russian stim, you can have gluteal contractions, which relieves pressure on those bony prominences. So that can be like a double-sided attack on pressure ulcers. Okay, so, and just the placement, the negative electrode is either placed on, let's go to the next slide. Oh, it's not there. Oh no. Okay. So the placement of the electrodes, the negative electrode is placed on or near the wound. You soak a little gauze and saline, put that on the wound if you need to put it on the wound, and put the electrode over that. And so we want it as close to the wound as possible. And the dispersive electrode is placed proximally above it. Okay, edema control. You can use this for edema control. The note with high volt pulse current is make sure that the edema is caused by either lack of motion or inflammation and not some malignancy. That's a contraindication. So you don't want to overwhelm an already failing organ system by pushing more fluid towards it like the heart. And that's why I say no CHF. I saw the study about it, so I included that, but I wouldn't use it on CHF because you're already taxing a failing organ system and you're increasing the risk for a PE, pulmonary edema. So. All right, and that is basically it on that slide. Again, I've included all those parameters based on research for wound healing, and with edema, you do set it to negative as well. Like an acute edema, you would use HVPC. A chronic edema, you can use biphasic, or you can use that muscle pump action from Russian as well, just to treat that. And that's for lack of motion. The chronic edema section at the bottom. Excuse me. This slide was supposed to be before. You can actually switch the polarity with the leads itself, or you can set the polarity on the machine. I set the polarity on the machine. And there it is being placed directly on the wound, the negative electrode. And that's it. Any questions? Oh, thank you. Okay, thanks, guys. Thanks for coming. I appreciate that. Okay. Yeah. I hope the handout helps.